Welcome to GEMCast, the Geriatric Emergency Medicine podcast, where we discuss important topics in the care of older patients in the emergency department. I'm your host, Christina Shenvi. GEMCast is produced with the Geriatric ED Collaborative. You can find more episodes on any podcasting app, and you can find the show notes on the resources page of gedcollaborative.com. Welcome back to GEMCast. I'm Christina Shenvi, and here with Dr. Meredith Busman, who is Director of Observation Medicine in Corewell Health West in Grand Rapids, Michigan. And we met because she's fellowship trained in observation medicine, which I didn't know that was a fellowship. Most of the time when I tell people I did a fellowship in geriatric emergency medicine, they didn't know that was a fellowship. So we are the lesser known fellowships club. But also she is directing the training program through ACEP to train other physicians how to do observation medicine. So Meredith, thank you for being here on GEMCast.
Thank you, Christina, and a proud card-carrying member of the Lesser Known Fellowships Club.
Excellent. I think we should make t-shirts. And the reason that Meredith and I are talking today is because observation medicine is a whole pathway and clearly a whole fellowship in taking care of patients who can hopefully be rapidly cared for and then discharged home. And I was interested in how can we make observation units or observation medicine friendlier for patients who are older or patients with dementia. Meredith, first off, what is an OBS unit? What are the goals or reasons that somebody might open an OBS unit?
Yeah, in observation medicine, we like to say that observation is a service, not a space. So it can occur in a variety of settings. Maybe that's in an emergency department, maybe that's scattered beds throughout the hospital, or maybe that's in a physically cohorted, dedicated unit. And so when we talk about an observation unit specifically, we're talking about an area of the hospital where we only have observation patients who are only being cared for primarily by an observation medicine team. And those patients are being cared for according to predetermined generalized protocols and pathways. If we follow that method of care, that would meet the definition for a type 1 observation unit, protocolized, cohorted patients. And that's where we see the best level of evidence for observation medicine as a whole. When we're caring for observation patients in a scattered throughout the hospital sort of space, or patients who are being cared for kind of using provider discretion, that's where we see these bad outcomes in observation with long lengths of stay, higher costs for patients and systems.
So having it cohorted and run by emergency physicians, and what's the evidence there in terms of having it run by an ED versus an inpatient team?
When we look at the studies, we see that there is consistently a shorter length of stay for patients who are cared for in a type 1 protocolized observation unit, especially when that's run by emergency physicians compared to hospitalists. And I think that has a lot to do with the mindset of emergency medicine and how we approach our patients, and that mindset of quickly turning patients over, getting tests, kind of being the SWAT team, if you will, focusing on one or two issues and really prioritizing those, thinking in terms of hours, not days.
So OBS units, good for those patients who have something that's relatively straightforward or need, say, serial exams or serial labs or a workup, a study in the morning, a treadmill test or something like that. I know some OBS units do those. But now let's think about specifically for older patients. And I want to give you an example case to walk us through about how good geriatric care could be done in an OBS unit and could be particularly beneficial for this patient population. So my case for you is one that you will probably see next week or next shift. It's an 82-year-old male with a history of hypertension, obesity, type 2 diabetes, depression, and sleep apnea, who's coming to the ED after a ground level fall. And he arrives around 8 p.m. We'll say he was, getting ready for bed and just tripped and fell 8 p.m. on a Thursday night. He normally walks with a walker because of some chronic knee pain. And from the fall, you've x-rayed him, you found he has a left humeral shaft fracture from this fall. So tell me about the journey that this patient could go through if OBS care goes well or maybe less well.
Yeah, so when we have a patient like this, we quickly arrive at a crossroads because you have a patient who really has, one specific injury and it's maybe not life-threatening. It is non-operative and seems like a fairly straightforward management. But the next steps that we take in managing this patient is really critical. So you could imagine one scenario where this patient remains in the emergency department overnight because there's no family available to come and get him until the morning. He might receive multiple doses of IV narcotics for his acute pain. And in the chaos of the emergency department, the long-acting insulin that he normally takes for his diabetes is not ordered. In the morning, his daughter arrives. Staff try to get him into the car with his daughter. However, he almost has a second fall because he can no longer use his walker due to that humeral fracture. Then the decision is made that it's unsafe for the patient to go home, and there's a plan to have him stay in the hospital for placement. He might be seen by the hospitalist later that morning. There's a delay to putting orders in as the hospitalist is rounding on other old patients or new admissions, and the patient isn't seen until physical therapy until late that afternoon, who may ultimately make a recommendation for subacute rehab. However, maybe now it's a Friday and there's no care management left in house to help evaluate that patient and help get the patient to an actual rehab facility. That may cause the patient to have a stay even over the weekend because we all know everything's slower on the weekend. That exposes the patient to the risk of hyperglycemia from having missed his long-acting insulin. That exposes the patient to developing delirium as he receives narcotics, has midnight wake ups to get vital signs. He doesn't have his glasses from home. And you can see how this can snowball into having multiple complications for the patient, exposing him to, again, the risks of delirium, medication side effects, hospital-acquired infections, etc.
This sounds 100% believable. I feel like I have seen this exact patient on multiple shifts where they have, I had a woman just the other day who had similar story with a humeral fracture. And in that case, it worked out okay. She was able to go home and she had family. But this is a constant challenge. And this point of, patients boarding in the ED for extended periods, either just waiting for discharge or waiting for other services or waiting for admission, this is such a fragile time because they are used to getting their home medications, their beta blockers, their calcium channel blockers, their insulin, all of these things. And in the ED, we're not used to ordering those types of things. We don't do home meds and home med reconciliations typically, but now we are having to because otherwise those patients will now become hyperglycemic or tachycardic or go into AFib. So this is such a treacherously dangerous time. How could
Yeah.
alternatively this go better if he came to your ED where there's this type 1 ops unit?
Yeah, and that's such a good point. I was working in the emergency department last night. It was chaotic. I had 12 patients all to myself. You're running around. I had a patient who was elderly and had a fall and was going to have to be admitted. It's hard to remember to order those home medications for a patient. And that's where the observation unit can really be helpful to the ED. Because let's now imagine a second scenario. Maybe the ED physician recognizes the patient has this upper extremity injury, had a fall, is at risk for complications, and the decision is made early on the same night that the patient arrives to the emergency department to place the patient in the observation unit. He ends up moving upstairs, getting placed in a separate room. All of his home medications, including his insulin, get restarted after a pharmacy reconciliation. Orders are placed, and he's seen by PT early the next morning who recommend subacute rehab. He's also seen by geriatrics while he's in the observation unit, and geriatrics discovers he's been taking Benadryl to help him sleep. It's thought maybe that could have contributed to his fall, and they recommend some medication adjustments, such as replacing Benadryl with melatonin. Care management has been involved in the patient's case since he came to the observation unit. And once they get the recommendation from physical therapy for subacute rehab, they're able to quickly coordinate a safe disposition, and the patient leaves the hospital within 24 hours. That is clearly a much better scenario for the patient, for the system, a true win-win. And it's true. It's the sort of care that we're able to provide in the observation unit where I work very consistently. It's not an unreachable goal.
This sounds so idyllic, and I love that it is a triple win. It's a win for the patient. Clinically, this is the right thing to do. It's a win operationally because now that patient is out of the ED so that now the ED can continue to see other patients, and the clinicians are not busy writing home med orders or diet orders or nighttime melatonin orders. That is now offloaded to whoever is staffing the OBS unit. And it's a financial win because now for the patient and the system, they're not taking up inpatient beds. That's worse for the patient. That's worse for the hospital system in our current environment where hospital beds are few and far between. So what you've described is a way to strategically use an OBS unit to allow older patients to have shorter length of stay, reduce their exposure to potential hospital-based infections, reduce functional decline, reduce the risk of delirium. I was just reading a paper yesterday. It's like a classic paper from the mid 90s about the dangers of inpatient stays for older patients. And one of the numbers that stuck with me was it said if you are, bedbound essentially or hospitalized for 10 days, it can take 4 months to regain your functional status for older patients. So one hospitalization for 10 days, 4 months that they might have to be working with PT to get back their strength, their balance, their muscle mass, their, coordination. That's incredible. That's a high risk situation for these older patients. Whereas if they could potentially have an OB stay where they get PT early, case management early, geriatrics consult, farm med rec, all of those things earlier, that's a huge win for the patient. So let's think through, you mentioned a few of these, but let's think through what are the things that an OBS unit could do to specifically help patients who are older, vulnerable, frail, or have cognitive impairment. And first of all, you mentioned using an OBS unit to minimize length of stay and reduce the potential harm from hospitalization. So how do you think about this with your OBS unit?
So when we cohort patients together and when we're following these specific pathways, we reduce care deviations in between providers or in between patients. Not to say that there isn't room for certain exceptions, right? But if we have a patient who comes in with CHF, for example, and we follow our congestive heart failure protocol, we know the patient will get certain dosing of Lasix based on their urinary output according to an algorithm we have built into our EMR. That's a huge thing. We know patients are going to get a cardiology consult to make sure that they are on maximal medical therapies. Patients will get an echocardiogram unless they've had one within the last 3 months. And once they've had kind of that standard care bundle of diuresis, cardiology evaluation, updated an echo, we'll then reevaluate the patient and assess whether they're suitable for discharge, whether they've had suitable improvement in their symptoms. If a patient's no longer dyspneic with exertion, no longer hypoxic, has diuresed well, that's a patient we'd consider ready for discharge with close outpatient follow-up. If a patient has been reassessed after those interventions and they've had clinical deterioration or worsening, well, now they've just defined themselves as necessitating inpatient care and can be appropriately transitioned to either cardiology or a medicine service. And being able to reassess a patient after completing a treatment cycle or a diagnostic cycle and assess their and kind of redisposition that patient, that allows us to significantly reduce our length of stay. The observation unit where I work, type 1 protocolized setting, has an average length of stay of 17 hours. Our sister hospital down the road has an observation unit run by hospitalists, and their length of stay is actually closer to 40 hours. So we can see where that ED mindset and following kind of strict protocols and treatment pathways has real world number impacts.
That's incredible. And I love this idea of, OBS units might not be for every patient. Clearly, some patients we know are going to need a longer stay or they need to go to the OR. But for these patients who have disease processes or pathophysiology that we can anticipate will take an expected course. Like if you have chest pain that's, maybe moderate risk, and I know, okay, you need a series of troponins, maybe you need, repeat EKGs, reassessment, and then getting on good therapy. That's something that can be done in 17 hours in an OBS unit. It doesn't necessarily need a 48-hour inpatient stay, and I really can't do it in a, 4 or 6 hour ED stay. So it's that in between, or the example you gave of CHF exacerbation. It's perfect. You mentioned also having case management or social work embedded in the unit and how, tell us more about that. Like, what do they do, and how does that impact care specifically also for older patients?
So having case management, physical therapy services, et cetera, involved and embedded in your unit is very helpful for a number of reasons. One, they are very familiar with the resources available in the community for this patient, whether that is navigating, getting home nursing resources, getting area aging resources involved, things like Meals on Wheels or home cleaning services to come by. They're knowledgeable in all of that. They can help set up rides for patients to make outpatient appointments. They can help talk with family members and provide education in terms of the support a family member might need when they go home. They can coordinate getting durable medical equipment like oxygen tanks, wheelchairs, hospital beds sent to a patient's home before they even leave the hospital. And those are the little things that will help a patient recover from their acute illness and reduce their chance of having a subsequent fall, getting dehydrated, getting weaker, having a new acute illness that sends them back to the hospital in the emergency department. I like to think of some of these interventions as soft medicine, right? It's not putting in central lines. It's not starting aggressive medications. It's making sure all those little things that can add up to make a big difference are addressed.
And those are the things, especially for older patients, that make such a big difference because for them, it's not just one thing, like the humeral fracture. I mean, if you or I got a humeral fracture, we would probably still be able to ambulate and mostly get dressed, and walk around and do our activities of daily living, or, at least use our phones to order some food or something like that. But for an
Right.
older patient who uses a cane or who can't prepare their own food with only one hand or doesn't have the resources to order food and needs like Meals on Wheels or something like that, those little things make so much difference to your readmission rate, your revisit rate, just how well they thrive at home. So I have to really emphasize that.
Yeah.
What about PTOT? So for this patient, or let's say somebody comes in with, a non-op pelvic fracture, like a pelvic ramus fracture we see all the time. And how would that work with PTOT in your OBS unit?
Yeah, well, you cited the study earlier saying about how long it takes for a patient to recover, to get back to their baseline level of function after a hospital stay. So we can't let a patient wait to get out of bed. We need to have that patient mobilized and assessed as soon as possible. And that's where PT and occupational therapy come in. So they can see the patient the very next day after their injuries, if they have a non-operative injury, and they can help us assess how is that patient managing their injury? How is their pain being controlled? Is that patient not painful at rest, but having severe pain with attempted mobility that then impacts their mobility, their movement that we need to be more aggressive with addressing? And they can help us make sure that we get the patient the appropriate resources, whether that's going to an acute rehab because they have a great potential for rapid return to baseline with aggressive therapies, whether that's into a nursing facility because we know it's going to take longer for that patient to recover from a fracture, for instance, or whether that's just getting a patient aggressive like home physical therapy. Another thing too is that they can help see what the patient wants, right? Not every patient is going to want to go to a subacute nursing facility, even if that's the recommendation. Patients may have a lot of reasons to want to return to their home as soon as possible, and physical therapy can help us bridge that gap to try and get the patient the resources they need.
PT and OT is so important, and also having the default be to get out of bed. Laying in bed all day long is not good for anyone really, for people who are young and healthy. And quick correction, the 10 days leading to 4 months of recovery, that is actually specifically for bone density. So vertebral bone loss accelerates to 50 times, like in this is in healthy men, if you're on bed rest. So if you're on bed rest, your bone starts to like reabsorb itself 50 times faster, apparently. And so 10 days of bed rest, it'll take you 4 months to get that bone density back, which if you're young and healthy, you have more homeostatic margin. Whereas if you're older and have osteoporosis, that's particularly bad. But then the muscle contraction, so specifically thinking about what PT and OT would add, muscle contraction, muscle strength decreases 5% per day if you are, on bed rest. And young men at bed rest lose muscle strength at about 10% per week. And I'm assuming, again, young, healthy men, this was, again, an older study, but young, healthy men have more muscle strength to start with versus if you're older, that's going to have an even more profound effect. So muscle strength, bone density, all of those things are worse if you have prolonged immobilization. So making the default be get out of bed, have PTOT, or somebody work with you.
And just think about when you're sick, right, Christina? When you're sick with the flu and you've been on the couch for 2 days, how hard is it to go up the stairs on that third day of illness? You're short of breath. You're really tired at the top. And that's for us, we're young, we're healthy. So then just magnify that to your elderly patients, and you can start to get a personal sense of how hard these hospitalizations can actually be for them.
Absolutely. Totally agree. You mentioned also getting geriatrics consults or getting pharmacy involved. Tell me more about what geriatrics does and which patients you might consult them on.
We have a great geriatric trauma service at our hospital, and I'm really grateful for the services they provide. Our geriatrics team will assess our elderly patients, specifically those who have had an acute traumatic injury, even including a fall without a significant resulting injury, such as a fracture. Maybe it's just they have acute on chronic knee pain. And they can come and assess our patients and offer a lot of really specific guidance. So our geriatrics team is knowledgeable in terms of what are our options for pain management? How much oxycodone, for instance, would be recommended in this patient with a history of renal impairment who's at risk for delirium? What are some alternate pain medications that might be available to us? What are best dosing practices? What medications does a patient take at home or that they've been prescribed in the hospital, which are maybe on the Beers criteria or at risk for having significant interactions? They can help educate providers, nursing staff on delirium prevention, such as making sure that patients have lights out, shades down at night, lights on, shades up during the day. They can help assess whether a patient is developing delirium. There is a clinical scoring tool for that called the confusion assessment method that they'll put into our notes to score patients on a daily basis when they see them, which is great. Helps educate nursing on early signs and symptoms of delirium because we all know detection is most important when it comes to kind of treating and preventing delirium. They can make sure a patient has things like their reading glasses, their hearing aids, that sometimes we can admit. And they can really take the time to be with patients and their families. They can spend an hour in that room where you and I might only have a chance for 15 minutes. So geriatrics is a great resource. And, you know, geriatrics can be a rare resource, but pharmacy's everywhere. And pharmacy is key because they can make sure we correctly reorder a patient's home medications, look for medication interactions, again, provide some recommendations on best practices for medications that are at higher risk of delirium or contraindicated in patients with certain conditions, such as decreased renal function, chronic pain, dementia, etc., and can make sure that we kind of optimize the patient's medical therapy while they're in the observation unit. And that can have long-term benefits for a patient, such as making sure their pain is well controlled, such as making sure their diabetes is better controlled or their blood pressure. Someone who's 85 doesn't need the same sort of blood pressure management as somebody who is 55, for instance. Those metrics change, and our geriatrics and pharmacy colleagues can help us meet those benchmarks.
You mentioned delirium a couple times, and this is another place where it's not just one thing. There's not one thing that you can do that will then prevent delirium or, you know, make delirium not happen for anybody in your unit. It's it's such a tough syndrome to tackle because you have to come at it from all the different angles. From things like sleep, you mentioned. Let's turn the lights out at night. Let's close the door. Let's have rooms that have doors that close. Let's, open the blinds during the day. Let's get them out of bed during the day, or even like put them in their own clothes during the day. Or another idea is to have cohorted meals if somebody's not infectious, like have them eat with other people. I mean, I've only ever been hospitalized when I had kids and when I had appendicitis when I was 13. And eating while you're in bed from those hospital trays is very difficult, even for a perfectly normal, functional person. It's very difficult. So normalizing their homeostasis as much as possible. And you mentioned the term soft medicine. I feel like this is strong medicine. This is like the hard things to do because I can very easily diagnose your humeral fracture. But to make to create an environment that minimizes your risk of delirium, that's the harder part at the end of the day because it's so many things. I'm curious if there are any other interventions that your nurses do or how you create a culture of like, don't wake the patient up for 5 a.m. labs, don't wake the patient up at 2 a.m. for vital signs, or how you help normalize all of those things.
I think it has to start really early on. I teach medical students and I do a lot of the modules I end up teaching at the med school are actually on things like falls and on the dangers that those pose to patients. And so teaching people early on, whether they're nurses early in their training, medical students, et cetera, that falls, vision difficulties, delirium, that these are big deals and shouldn't be looked over as just normal parts of aging, can help change the culture and maybe change some of the stigma around them and help people recognize that these are real medical problems or medical problems in waiting, right? So if we wait to care about a patient's frailty until after they've had a hip fracture, well, they've already fallen and had that hip fracture. We could have taken the initiative before to assess a patient's getting weaker, maybe has balance issues, maybe is suffering from protein calorie malnutrition, and made interventions like getting that patient into a structured physical therapy program, getting them nutrition supplementation, and prevented that fall from happening in the first place. I
Absolutely.
Yeah, I think if you educate nursing and residents on the little things that they can do when they're at the patient's bedside, like the classic opening the blinds during rounds, that adds up. If you empower all of your care providers to do the little things that add up, I think that can together make a difference and help people take responsibility for these
hmm
patients.
hmm Strong medicine. So I'm going to make that term happen. So we talked about delirium, but what if, let's say, a patient has some cognitive impairment and often in the evenings, quote, sundowning, they can have worse behavioral or psychological symptoms from their dementia or start to become more agitated. What are some things that you do or that you would avoid doing in your OBS unit to try to, maintain function and prevent escalation?
I said it earlier, delirium prevention is the best practice here. But like you said, sometimes that just can't happen. And when we have a patient suffering for delirium, there are a couple interventions that we can do. The first off is attempting to reorient the patient. If you have a family member or a trusted individual that's able to be at bedside, even stay overnight with the patient, that's a great resource. You never want to use restraints in a patient with delirium. That's dangerous for the patient. It can result in injuries for the patient and the staff. It can worsen delirium. So never use restraints unless absolutely necessary. Same goes for any sort of medications because no medication is going to be completely safe in these patients. But if you have a patient with agitated delirium, then there are some best practices regarding medication use. First off, no benzodiazepines, no anticholinergics. If you have to use a medication, best practices are using an antipsychotic such as risperidol, which is a little less sedating than some other medications, or olanzapine. I was reading this morning that Depakote can also be used for patients with QTC prolongation, greater than 500, since it doesn't prolong the QT such as those other antipsychotics I mentioned. And getting your geriatrics team again involved can be helpful to make medication recommendations once you have a patient suffering from acute delirium. If you're able to additionally reorient the patient by improving sleep-wake cycles, reducing any interruptions at night, such as no vital signs in between 10 p.m. and 6 a.m., clustering interventions such as drawing labs and administering medications in order to reduce disruptions for the
Mhm.
patient.
So let's think now about discharging the patient, because this is another transition of care that you want it to go smoothly. You want the patient to have follow up. And what are the things that you can do in your OBS unit to help make sure that that transition home or to an outpatient facility is successful?
So when we're discharging a patient, there are a few things we can do. We can place referrals for home physical therapy, home health services, as well as for any specialty follow-up a patient needs, such as follow-up with orthopedics for an acute traumatic injury. Sometimes we refer a patient to neuropsych if we have concerns for cognition, for dementia that maybe previously has been kind of covered up, but is now more obvious, and we think the patient needs formal testing. On occasion, we'll be able to have the patient seen by neuropsych while they're in the observation unit. More often we'll refer them at discharge, and we'll also be very clear with communicating with the family our concerns for an underlying dementia and the need to follow up with neuropsych for formal cognitive testing. And we also need to make sure we have a very clear discussion with family about safety interventions. Maybe that is taking away the keys. Maybe that is making sure somebody comes and checks in on the patient if they're going to be at home by themselves for prolonged periods of time. And then finally, we need to make sure that patient has basic PCP follow-up. Our care management team is very good with helping patients make PCP appointments before they even leave the observation unit, especially if that patient isn't currently established with a PCP, making sure that we get them in, make that first appointment. If you're really lucky, you may have the ability to bridge a patient. Our group has a same day walk-in style emergency department clinic that's run by physicians that we're able to use as a bridge for patients after they're discharged, where they can go be re-seen. We can check in to see whether their COPD or their heart failure is still doing okay, provide additional medications, maybe repeat some labs, and make sure that we can get that patient through until they're actually able to follow up with their PCP or specialist.
That's amazing. I love that you can get them an appointment before they leave because often just saying, "Hey, follow up with your doctor" feels like a bit of a black hole because you don't know if they're going to be able to, you don't know if they have transportation, you don't know if their PCP is still there or is on vacation or has moved somewhere else. So it can be a very risky time when you're transitioning somebody to home. So at least giving them an appointment, or as you mentioned, your next day or same day clinic where people can be reassessed. Maybe they need one more dose of that IV Lasix, or maybe they need one more neb, or maybe they, need one more dose of IV ceftriaxone for their cellulitis. And that way they can get it without having to come back to the hospital or back to the ED in order to get that last dose. And I would imagine, I don't know if you have numbers, but I would imagine that helps a lot with reducing ED revisits as well as ED hospital readmissions.
Yeah, and we all know how hard it is to navigate the medical system and how quickly patients can fall through the cracks. Plus, I think everyone likes having a plan. Everyone likes knowing I'm leaving the hospital now, but here's my next step. And if we're able to provide that to patients, I think it not only helps them from returning because they got lost in the system, they couldn't get their appointment in 3 days like we told them to, but it also provides them a measure of reassurance that they're going to be okay, that we care about you, that we're following up on this condition, and will kind of reduce some of the patient's, fear about their illness.
Absolutely. So let's say you were giving advice to another physician who wants to create a type 1 ED run OBS unit. What are some key things that help you be so efficient? I mean, you've talked about this average 17-hour length of stay where you get all of these things done, this protocolized care. What are the keys to success to maintaining that throughput and that flow?
When you're first starting this discussion, it's really important to get your hospital leadership, your hospital C-suite on board, because you need to get them invested in the observation unit. Observation units are not inpatient floors, they are not high revenue streams, but they provide a lot of valuable services to patients and to the hospital system in other ways. First thing you're going to have to do is educate leadership that your observation unit will not be full 24/7, even in a busy, well-run unit. And that's because we have a length of stay less than 24 hours. A lot of observation units will have a high census in the morning as patients are being re-seen, rounded on, and discharges are starting to happen. They'll have a low census in mid to late afternoon as all of the discharged patients end up leaving. And then they'll have a high census in the evening as the emergency department gets busy, patients are coming in, and we're getting new admissions. If your hospital sees the observation unit as being, quote, empty in the middle of the day and tries to put inpatients or boarders in your unit without understanding you'll need those beds later, it's a huge cause of inefficiency because now you end up just boarding those observation patients and creating a longer length of stay where there doesn't have to be. So make sure your hospital understands the ebb and flow of observation patients and that that space needs to be cohorted, needs to be designated for observation patients only. And they're going to see the benefits ultimately by a higher turnover, not only of those patients, but of patients throughout the hospital as you offload other services, such as medicine and specialty services, by managing those patients yourself. The other thing that you need to have on board are good protocols and pathways. And fortunately for us, there's been a lot of research done that's widely available and well published through a variety of resources, books, online, there's conferences. Make sure that you have those protocols and pathways in place from day one so that you start with an efficient workflow and that you have your consultants and specialists on board, that they understand what you're doing for their patients and how they can help you. If you don't have support from the cardiologist about you ordering stress tests, for instance, that's going to be a big barrier into your care.
Well, Meredith, thank you so much for sharing your wisdom and experience and knowledge on how to make observation medicine safer and better for older patients. You have an awesome grasp on this, and It is not within my power, but I would love to make you an honorary geriatric EM physician also, in addition to observation medicine, because you're just doing great work and this is strong medicine. So thank you for joining us and thank you for being on GEMCast.
Thank you, Christina.
Thank you for listening to this episode of GEMCast. You can connect with me on Twitter with the handle @GemPodcast. You can also navigate over to gedcollaborative.com for more resources on the care of older patients.